Mental health, ready, set, assess for success. A counselor shares which assessment addresses your student's needs. This webinar is presented by eTherapy, and we wanted to share a little bit about who we are. eTherapy is led by a team of individuals who are really experts in special education services. And our team has been on the forefront of innovation with technology as pioneers in the field of teletherapy. E-therapy began when telepractice was still a brand new concept, and we have innovated to meet the needs of students across the country so that those students who may not have access to an on site therapist can still receive the IEP services they need. We're really proud to be able to change students' lives for the better by providing those services. Our mission, passionate about your student needs, eTherapy brings best-in-class technology and superhero focus to raise your level of educational service. That's what we're here to do. As a national leader in teletherapy, eTherapy was one of the first teletherapy companies starting up in 2009, and we provide special ed related services to students across the nation from early education all the way through 12th grade. We provide speech therapy, OT, PT, and counseling or mental and behavioral health services. We work with traditional brick and mortar school districts, charter schools, virtual schools or cyber academies, urban and rural schools across the United States, from Alaska to Washington to New York and Florida and everywhere in between. And we've also worked privately with families in the US and internationally. So, why does eTherapy exist? Well, there's a shortage of therapists and special education personnel overall across the country. Many schools just can't find enough on site therapists to fill their needs. Some schools may be very remote and have a difficult time finding therapists who can easily access their location, or it may be a very metropolitan district where the needs are just so high that there aren't enough related service staff and therapists to fill the need. There are also compliance issues. Schools are required to provide the services that are outlined in a student's IEP, and if the school does not provide those services, they can be out of compliance with federal mandates. There are also budgeting considerations. Schools may be spending a lot on staffing or transportation cost for their therapists to travel to multiple sites or campus locations. Schools are also facing a lack of consistent services because they may have difficulty retaining therapists. In addition, we're seeing an increased demand for counseling and mental health services across the country, which has in turn led to an increased need for mental health providers in our schools. So, as many schools are facing these problems, eTherapy offers a solution that can help fill that gap. With teletherapy, students can log on to their sessions with a therapist in real time online so that they can get the services they need in a high quality and consistent format. As I just mentioned, one area of those services is online counseling or mental and behavioral health services. The need for counseling intervention is ever increasing. And that leads us into our topic for today. We have with us Makisha Gunty, who is going to talk about mental health services and how we can measure progress to determine if students are getting better. We are so happy to have Makisha with us here today. And here's a little bit about her. She has a bachelor's degree in human development and family studies with a minor in sociology and a master's degree in social work. She is licensed with the Arizona Board of Behavioral Health Examiners as a licensed master social worker. Makisha has 19 years experience working in social services, holding several positions in management and administration, behavioral health, child welfare, and prevention programs. Additionally, Makisha has experience in higher education as adjunct faculty with Arizona State University and Grand Canyon University. Makisha served as the Assistant Executive Director of Arizona Partnership for Children, LLP, from 2014 to 2016, was a steering committee member of the Maricopa Family Support Alliance from 2014 to 2016, and has been a member of the National Association of Social Workers since 2011. And here are our learner objectives. After completion of this webinar, the participant should be able to interpret assessments that show clinical progress in behavioral health treatment, explain a way to monitor progress in behavioral health treatment over time, and identify when your student's behavioral health is getting better. And now I will hand it over to our presenter, Makisha Gunty.
Thank you so much for that wonderful introduction and review of our learning objectives today. And thank you to everyone that has joined us. I want to first start with common behaviors and or experiences that you may see exhibited from those in your classroom. They include aggression, anxiety, bullying, and maybe the bullying, they're either a witness to the bullying, or they are the bullied, or maybe they are doing the bullying act themselves. You could also see just general unhealthiness, impacted mood and depression. Maybe a medical condition that they have is causing certain behaviors in the classroom or causing complications for them and their learning. You might also see parent-child relationship difficulties, and that could always manifest in your classroom. I probably don't need to be the one to tell you that. Poor coping mechanisms, reduced self-esteem and lack of confidence, risky behaviors and or increased risk factors, which cover quite a bit actually. Substance use or abuse, trauma, and then unhealthy relationships with food and or eating behaviors may or may not have been so severe to reach an actual diagnosis of an eating disorder. So these are several things you may see in your classroom and or seeing the behaviors in the classroom that are caused by some of these experiences and or related trauma. So whether you were the one that recognized they needed help and made the referral, or the family self-referred, or for whatever reason that they went to seek help, we'll review what I would call the ideal help process, which is where someone will have seen a behavior and or a symptom, the family and or child was referred for services and they enroll for services, and again that can include self-referrals. They receive treatment, they progress in treatment, and then they discharge from treatment. That's really kind of the ideal process that would be followed, and the hope is that they would progress in treatment and be able to discharge in a relatively short amount of time. So today's focus is really going to be about that progress and what does that look like and how do you tell when somebody's getting better. It can be difficult in a behavioral health setting to be able to determine and exhibit if a child is getting better and or if their symptoms are getting better. That's really due to behavioral health really being more of a soft science than, say, the medical field being a hard science. When you go to the doctor and you have, let's say, bad cholesterol, and the doctor takes blood and sends it to the lab and you get your results back and there's a hard number, right, that says your cholesterol is this number and it should be within this range, and you're either in that range or you're out. And so there isn't a test like that, as you well know, for depression or anxiety. There is no blood drawn or a marker that can tell you where you fall. And so that makes it really difficult to show progress and or getting better with hard data. And behavioral health has had to rely more on qualitative data, so more narrative on how you're feeling and self-reporting. We have over time used service plans and that helps attach it to more of a hard number. How many depressive episodes have they had in the week? And that makes it slightly easier, but definitely not as easier as hard science of the medical field. So, in behavioral health, being able to use assessments in order to show clinical progress is very important. And through these uses of assessments, you're able to show some longitudinal data so that you can show over time things are getting better or they're not. And of course, the hope is that the symptoms are reducing and or getting better. So, the using of assessments to show clinical progress is one way to show that progress is being made in treatment. You'll see I've highlighted on this slide the various behaviors and or experiences tied to which assessments, and then I've also included the information on whether they are free or there are copyright needs. And I tried to choose various ones to show, free ones as well as ones that are copyrighted. I think it's important that you're able to walk away today with assessments that you are able to interpret and that are more likely to be used due to them being free. These are not all inclusive of the assessments that could be used, let's say for aggression. There are multiple assessments for aggression, but I wanted to review common ones today and ones that were free. So you're able to see for aggression, the one we will cover is called the Modified Overt Aggression Scale, MOAS for short. For anxiety, we will be reviewing the Generalized Anxiety Disorder, GAD-7. For general well-being, we'll be reviewing the Personal Well-being Index for school children. There are various versions of that index. The one we'll be covering today is for school children. We will not be covering the ACORN Child Outcome Questionnaire because of its copyright, but I did want to list it here so that you were aware of another well-being index that could be used. For mood and depression, we will be reviewing the Patient Health Questionnaire, PHQ-9. This is something that you may see either therapists use and or a pediatrician or a medical professional. Or used in a medical professional setting. For parent-childhood relationship difficulties, you can see that I've listed the Parent Relationship Questionnaire, PRQ. We will not be reviewing that one today. For coping mechanisms, the COPE inventory is mentioned here. For reduced self-esteem and lack of confidence, I've referenced the Rosenberg Self-Esteem Scale, which we will be reviewing today. For substance abuse, I have 3 listed, all free, although we'll only be covering the first one, the CRAFT 2.1 version. Addiction Severity Index is mentioned, as well as the Drug Use Questionnaire, DAST-20. For eating behaviors, I've listed 2 here that are copyrighted: the ACORN Eating Disorder Questionnaire and the Eating Attitudes Test. The EAT 26 has 26 questions. There are a few different versions of the EAT. They are frequently used by medical professionals in evaluating behaviors around eating. You'll see those, as I said, in the medical community for use. However, you may, in your multidisciplinary teams, you may encounter either of those assessments, and so I wanted to mention them here. So in this slide, you'll be able to see just kind of a snapshot of the ones we'll be reviewing today: the MOAS, the GAD-7, the PWI-SC, or Personal Wellbeing Index for school children, the PHQ-9, the Rosenberg Self-Esteem Scale, and the CRAFT 2.1 version. Let's go ahead and jump in, and I want to give you a quick picture of James. Let me introduce you to James. James worries about school performance, worries about friendships, worries about siblings as well. He's got siblings at home that he definitely stresses about. He has trouble concentrating. Is restless. Is restless not only in class but also at home. He has trouble sleeping, can't sleep, gets little sleep, has frequent belly aches. Sometimes his mother believes that there is some sort of pattern associated to them, when in school it's hard to tell that pattern. So sometimes there's a pattern to his belly aches and sometimes there isn't. And this has been going on for many months. Okay, so what can be done? There are varied forms of treatment and modalities, and he might be receiving services on an outpatient basis, and that could look like receiving just counseling from a therapist. He could also be with an outpatient facility and receiving psychiatry and medication monitoring, and have services through that outpatient behavioral health through a case manager. But he may just be receiving counseling, or maybe he's not receiving services yet and does need those services. So the assessment provider that would be working with James might use the generalized anxiety disorder, the GAD-7. Now, the GAD-7 is used to identify and monitor anxiety disorders, including panic, social anxiety, and post-traumatic stress disorder. And so the GAD-7 uses a Likert scale scoring system, 0 through 3, and the GAD-7 is a self-report, which means that James is going to end up answering these questions himself. Now, James is a little young, and so the reading may not be where it needs to be. And so it's all right. The therapist may end up asking him the questions and recording the answers on the sheet themselves. But nonetheless, it is a self-report. So this will be James' perception. It does have 7 questions, can be used for ages 12 and up. The time to administer it is usually about 2 to 5 minutes and can be done every 2 weeks. All right. And you're able to find this in multiple languages, more than 20 languages, so that the language isn't a barrier. You can see that the 7 questions for the GAD-7 are listed there. They include the first one, feeling nervous, anxious, or on edge. And remember, it's a Likert scale. So he'll use the answers 0, which means not sure at all, through 3, which is representative of nearly every day. Now, reminder, this is over the last 2 weeks. And so that is the range in which the reporter child will look back and consider that time frame when answering these questions. Number 2, not being able to stop or control worrying. Number 3, worrying too much about different things. Number 4 is trouble relaxing. Number 5 is being so restless that it's hard to sit still. Number 6 is becoming easily annoyed or irritable. And number 7 is feeling afraid, as if something awful might happen. You can see that the therapist would be adding up the scores for each column to get a total score. And I have done on this slide a graph to show you what progress over time might look like. And I mocked up a GAD-7 graph for James, and you can see that he took 4 of these assessments over 8-week time span. And so his first assessment was on January 15th, 2019. And you can see that he answered for question number 1 about feeling nervous, anxious, or on edge. He answered with a 3, which was nearly every day. Question 2, can't control worrying. Again, he answered with a 3, representative of nearly every day. And so we have used this graph over time to show that he is progressing in his treatment, and his symptoms are getting better. If you were to compare January 15th, 2019 to February 26, 2019, you can see that his scores reduced. Question 1 of feeling nervous, his baseline or first assessment that was completed, he responded with a 3 nearly every day, and you can see it reduced over time to, on February 26th, 2019, to a 0, which was representative of not at all sure. I'd like to draw attention to question number 3, which asks, worrying too much about different things. You can see on January 15th, 2019, he responded with a 2, which is over half the days. You can see his next assessment, January 29th, 2019. The symptom actually got worse, and he responded with a 3, which was nearly every day. And then you can see February 12th and February 26th. Those both reduced back down to a 2. So they met his baseline. Progress doesn't always look in a straight line, right? It can increase and decrease, and so the idea is over time it would hopefully decrease exponentially. You can see by this graph that James's anxiety has reduced on the last assessment that he was given, February 26, 2019. You can see that there are 2 zeros, 4 ones, and only 1 2. So this would show that he has made progress over time and that his anxiety symptoms have decreased. So that is an example of how the GAD-7 might be used to show clinical progress of reduced anxiety symptoms over time. And you might encounter a graph like this in maybe one of your multidisciplinary teams or in a child and family team meeting with the family and the therapist. And so this will enable you to be able to interpret, be familiar with the GAD-7 and be able to interpret those scores. We'll go ahead and move on and introduce you to Sam. Sam falls asleep in class, and when he is awake, he's kind of dazing off, looking out the window, distracted. He doesn't show much excitement, and he doesn't really eat much at lunch. And his self-talk includes calling himself stupid. So Sam may or may not be in treatment, and that treatment may include various modalities. He might be receiving services on an outpatient basis from either therapy, a therapist, a psychiatrist, maybe with a behavioral health organization receiving case management. And so an assessment that might be used with Sam would include the patient health questionnaire. It's used to assess and monitor depression severity. It does have a scale of that 0 to 3 Likert scale. It is a self-reporting tool, and so the child in this instance will be reporting that information. It does have 9 questions. There is a 10th at the end. It's for ages 5 and up. The administration time is about 5 to 10 minutes, and so a lot of times these can be done in the waiting room prior to meeting with the therapist and or the doctor. These can be given daily, which is a really good tool. As you know, things can change, symptoms, feelings can change from day to day, and it can be used, it is translated in more than 20 different languages, so it can be used, no barrier there. As you can see, the questions for the Patient Health Questionnaire 9 is looking back over the last 2 weeks, has there been little interest or pleasure in doing things? 0 representative of not at all, and 3 representative of nearly every day. Question 2, feeling down, depressed, or hopeless. Question 3, trouble falling asleep, staying asleep, or sleeping too much. Question 4, feeling tired or having little energy. Number 5 is poor appetite or overeating. Number 6 is feeling bad about yourself or that you're a failure or have let yourself or your family down. Again, referencing that self-talk and self-esteem and feelings. Trouble concentrating on things, such as reading the newspaper, watching television. Number 8, moving or speaking so slowly that other people could have noticed, or even the opposite, frenetic, fidgety restlessness, that you've been moving around a lot more than usual. And thoughts, number 9, thoughts that you would be better off dead or hurting yourself in some way. Again, these are Likert scales 0 to 3. You would add the columns together, add to get a total score, and then question 10 is if you checked off any of the problems above, how difficult have those problems made it for you to do work, take care of things at home, or get along with other people. And then that one has a scale, a 4-point scale as well. So you would have the child, whether it would be you that would have the child, rather the therapist and or the medical provider would have the child fill this out, go ahead and score it, and likely then meet with the parent or child to discuss the scores. You will see in this next slide, I've done examples of PHQ-9 for Sam. So on January 15th, when Sam came in, he scored pretty high, several 3s, a few 2s, some 1s. Then in subsequent weeks took the PHQ-9 again, and you can see that one of them, trouble with sleep, got worse, and the others started to get better as treatment was continued. You can see from January 15th to February 26th, several symptoms reduced, either from 3s all the way to 0. Either you can see several remained the same, even with his trouble sleep at the end. But his little energy got better, his appetite got better, feelings toward himself got better, trouble concentrating got better, and speech and behavior and self-harm feelings got better as well. So in this example, Sam received treatment and progressed, and you can see in his graph that it shows those symptoms have reduced. So if you were exposed to a PHQ-9 and or the results for one of your students, and it showed that hopefully it will show that things are getting better. Nonetheless, you'll be able to interpret this data if you are exposed to it. So we're so happy that Sam is getting better. I would like to introduce you to Yolanda. She overall presents as dissatisfied with most things, to include her home life, tangibles, what she has, her health. She claims she doesn't have any friends or little friends, lack of safety, and then her future. Whether she is in treatment or not, there might be several different types of treatment and or modalities used. She might be receiving services on an outpatient basis, as we have described before, although dependent upon how severe her symptoms are and what her circumstances are, she might be receiving intensive treatment either in the home or out of the home. So an assessment that the provider might use would be the Personal Wellbeing Index for school children, PWI-SC. A description of this assessment: it is used to measure personal well-being in school-age children and adolescents as defined by those categories. Their satisfaction with the following domains: standard of living, health, life achievements, personal relationships, personal safety, community connectedness, and future security. So each question is scored using a Likert scale of 0 to 10, so much more options than the previous Likert scales that have been used in the previous assessments. This is another self-reporting tool, so it is the student that would be reporting their feelings. There are 7 questions, can be used for children ages 5 and up. The administration time is about 2 to 5 minutes. Now you could administer it daily, and it does come in more than 5 languages. So I did note on here, you can see that there is a preschool age children version as well, although we'll be covering today the one that is for school children. So the 7 questions that go along with this school children questionnaire includes, you can see the first question is about standard of living. So how happy are you about the things you have, like the money you have and the things you own? And the Likert scale of 0 to 10, 0 represents very sad, 5 represents not happy or sad, and 10 represents very happy. Question number 2 has to do with personal health. How happy are you with your health? Again, 0 to 10 Likert scale for all questions. Question 3 is about achievement in life. How happy are you with the things you want to be good at? Number 4 is how happy are you about getting on with the people that you know? Question 5 is related to personal safety. How happy are you about how safe you feel? Question 6, how happy are you about doing things away from your home? And question number 7, how happy are you about what may happen to you later on in your life? So those are the 7 questions for the Personal Wellbeing Index for school children. And you can see, again, I did a mock-up of showing Yolanda's progress over time. The first assessment she was given on January 15th, 2019. You can see her standard of living, question 10. She was very happy with money that she has and the things that she owns, those tangible. Personal health, she was happier with her health. You can see this is an inverse progress. So we want this scale to go up because the higher the score, the happier she is. And you can see over time it is actually reduced. So Yolanda has not shown progress over time. Yolanda has decreased in her happiness with life overall. That could be due to various things. But the good news is right now, because someone is giving her these assessments, that she is in treatment, and they may need to look at various other assessments to determine what's going on with her, maybe some screenings for depression, or maybe this is situational and there's some event going on in her life that's causing these scores to go down. So it's important when looking at data that you're able to know the questions to the assessments and be able to determine, is the client getting better or are they not? Had we just looked at this data without really looking at the questions, we would have suspected that she was getting better because the symptoms were reducing, when in fact the assessments used to monitor happiness over time, and so we really want those numbers to go up. So in this example, Yolanda is not getting better. Something's going on, and this would enable those that are interpreting this assessment to be tuned into that and be able to have hard data or numbers to show that something's going on, and there needs to be some questioning and some maybe assessment of other conditions because her well-being is decreasing. All right. I would like to introduce you to Joseph. Now, Joseph has destroyed property intentionally and out of emotional expression, I'll say. Screams and throws tantrums, has hurt himself, gets into school fights, frequently acts out and has behaviors that exhibit that, and is being assessed for Asperger's or autism. So several things could be going on with Joseph, and he could be receiving any type of treatment. He might be receiving in-home services, services through an outpatient setting, or depending on the severity of his symptoms, may be receiving services in an inpatient setting as well. And as I referenced that severity, he might have had involvement with law enforcement, mental health crisis response, and or inpatient treatments, and that really just depends on the severity of those acting out behaviors. An assessment that might be used with Joseph is the Modified Overt Aggression Scale, the MOAS. It's used to evaluate the frequency and severity of aggressive episodes. Assessment has 4 types of aggression that it details: verbal aggression, aggression against property, autoaggression, as well as physical aggression. Each category has 5 optional responses that are cumulative when calculating the score. So it is a self-report. Having said that, a caregiver is also able to answer this assessment. Can be used on ages 5 and over. The administration time is about 2 to 5 minutes, so not long at all. Can be done weekly and is in English. So here's an example of the Modified Overt Aggression Scale, the MOAS. You can see the first one, which measures verbal aggression. A 0 score would be no verbal aggression. A number 1 includes shouts angrily, curses mildly, or makes personal insults. Number 3 is impulsively threatens violence toward others or self. And number 4, threatens violence toward others or self repeatedly or deliberately. Now, the difference in this assessment is you will end up checking all boxes that apply. So you end up having a sum in that category for verbal aggression that could be more than 4. So if you had a child that impulsively threatened violence towards others or self and threatens violence towards others or self repeatedly, they could score a 3 and a 4 on that scale, giving them a sum of 7 for the verbal aggression score. You can see the questions and or cues for aggression against property include no aggression against property, slamming doors, ripping clothing, urinating on the floor. A number 2 is throwing objects down, kicking furniture, defacing walls. A number 3 is breaks objects, smashes windows. And number 4 is sets fires through throws objects dangerously. So those are all aggression against property. And then the assessor would sum up the property aggression score. You can see in each category the max score would be a 10, and so in just the sum. Now you can see below at the bottom there are weights, and so then you have a total weighted score as well. And it would be the assessor that would end up scoring this. The family does not score this, as you can imagine. So let's go through the graph and showing progress over time. You can see that I graphed them as the sum score, not the weighted sum. So that graph, the weighted sum graph, would look a little different. This one is the sum score. And so you can see for question 1 on verbal aggression that Joseph had a score of 10. So he was extremely verbally aggressive and scored on each of the subscales that were there. For property, he scored a 2. Aggression against property. For autoaggression or aggression against himself, he scored a 3, and for physical aggression, he scored a 6. Now, you can see by the 4th assessment that he was given, those scores have reduced, so his symptoms have reduced. He has shown progress, right? We want them all to show progress. So Joseph has shown progress over time in his aggression. Gives us about a month and a half looking out for those assessments. His verbal score reduced from a 10 to a 3. His property reduced from a 2 to a 1. His self reduced from at baseline from it stayed the same from a 3 to a 3, so that did not reduce over time. And then his physical reduced from a 6 to a 1. So the only subscale that did not show progression over time was self and his autoaggression against himself. So, as you can see here, if you were exposed to a MOAS and needed to interpret that progress, you would be able to know that this particular assessment does want to reduce the scores over time. It was not like the previous assessment, the PWI, in which we wanted the scores to get higher. This one we do want the scores to get lower for the MOAS. All right, let's move on and let me introduce you to Rachel. Now, Rachel has substance use difficulties. Sometimes that includes alcohol, marijuana. I've also listed hash, vaping, spice, prescription drugs, over-the-counter drugs. The assessment we're going to cover can monitor all of those, I'll say. What can be done or what treatment might she be receiving? Could be in an outpatient clinic, dependent upon the severity and or frequency. She might have had involvement with law enforcement, mental health, crisis response, or inpatient treatment, again, depending on the severity. Now, an assessment that a provider might use would be the CRAFT, and this version I'll be showing you is the 2.1. It's used to identify substance use, substance-related riding and driving risk, and substance use disorders. It is a 2-part screener and questionnaire. The screener part A is 3 questions, and then part B is 6 questions, both with yes and no answers. It is a self-report, so the student and or child will be reporting the information. As I said, it does have 2 parts and 9 total questions. It is for children ages 12 to 18. The administration time, again, is 2 to 8 minutes, so very short. Frequency is every 12 months. So this is more longitudinal. This is going to be a lot of time in between these assessments. And there are English versions. So here's an example of the craft 2.1. You can see that the first question is the screener, part A, is really prefaced with a question, and it is intended to be asked of by the therapist rather. So you begin by saying, I'm going to ask you a few questions. Please be honest. I'll keep your answers confidential. Part A, during the past 12 months, on how many days did you 1. Drink more than a few sips of beer, wine, or any drink containing alcohol, and then put a 0 if none. And if the therapist needs to help the child answer that in the format of a year, you may go from weeks to months to years to get that number of days. So during number 2, during the past 12 months, on how many days did the student use any marijuana, which includes in this one synthetic marijuana, so weed, oil, hash, vaping, or in food. And then synthetic marijuana would include K2 or spice. And so then you'd put the number of days. And during the past 12 months, on how many days did you use anything to get high, like other illegal drugs, prescription drugs, over the counter, etc. So did the patient answer 0 for all the questions in part A? If the answer is no, then you ask all 6 craft questions below. If the answer is yes, ask the car question only, and then stop. And so that's the first one. So part B includes the acronym for craft, right? So car. So have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? And answering yes or no. Then R for relax. Do you ever use alcohol or drugs to relax, feel better about yourself, or to fit in? Yes or no. A, do you ever use alcohol or drugs when you are by yourself or alone? Yes or no. F, do you ever forget things you did while using alcohol or drugs? Yes or no. Second F, do your family or friends ever tell you that you should cut down on your drinking or drug use? Yes or no. And then T, have you ever gotten into trouble while you were using alcohol or drugs? Yes or no. And so then the way that would be scored, 2 or more yes answers suggest a serious problem and need further assessment. And so then the therapist would follow up on that. There is a version for teens as well that has more questions that the therapist might use. I did not include the teen screen on here. It's much more questions. And I thought we just needed to cover maybe the short version today. I did not graph this one out. I didn't want to inundate you with you too much. But as you can see, those are the questions that might be used if a therapist was using. Those are the questions that would be used if a therapist was using the Craft 2.1 version. And so if you encounter this, you will have knowledge on how to interpret and know what the questions are asking. Next, I'd like to introduce you to Nina. Nina refers to herself as an idiot, can't name one good thing about herself, and already has a diagnosis of depression. So she may be receiving treatment in an outpatient setting, or depending on that severity, she might have received inpatient treatment. She might be with a therapist that using an assessment called the Rosenberg Self-Esteem Scale. Now, the Rosenberg Self-Esteem Scale is used to measure global self-worth by measuring both positive and negative feelings about the self. It is a Likert scale as well, 4-point Likert scale. The Likert scale includes strongly agree, disagree, and strongly disagree. Now, it is a self-report tool again, has 10 questions, can be used with ages 12 to 18 years old. The administration time is about 5 to 10 minutes, can be used daily, and comes in 5 different languages. Now, you can see question number 1, I feel that I am a person of worth, at least on an equal plane with others. The student or patient would answer strongly agree, disagree, or strongly disagree. 2, I feel that I have a number of good qualities. 3, all in all, I am inclined to feel that I am a failure. 4, I'm able to do things as well as most other people. 5, I feel I do not have much to be proud of. 6, I take a positive attitude towards myself. 7, on the whole, I am satisfied with myself. 8, I wish I could have more respect for myself. 9, I certainly feel useless at times. And 10, at times I think I am no good at all. So those are the 10 questions on the Rosenberg self-esteem scale. Again, they would mark strongly agree, agree, disagree, or strongly disagree. We would hope that their self-esteem would increase over time. And for example, on question number 1, I feel that I am a person of worth, at least on an equal plane with others. Our hope would be that it moves from disagree or strongly disagree to agree or strongly agree. Now, I did not do a graph on this one. I figure you are all graphed out, but seeing this progress over time, even if you were to compare just one assessment to another or to compare multiple in a run chart or graph setting, then we would be able to see that progress over time. I really wanted you to be familiar with the assessments, free assessments that might be used for the various symptoms that we detailed, and at least be familiar with looking at the assessment and be able to interpret which way the scores would need to go and be familiar with using an assessment to monitor said progress. So, really, today has been about what does better look like and how is it measured for students and or clients with various symptoms, and to show in a longitudinal way over time. The hope is that through using these assessments in a behavioral health setting, that you can show that progress over time for a soft science compared to, right, a hard science of the medical field. And as we discussed, that showing progress for cholesterol is very different than being able to show progress for depression. So really, what next? If you have a child in your classroom, a student in your classroom that you do believe needs services, you're able to follow one of many avenues. You could talk to the parent about your concerns and see what their willingness is for self-referring for treatment in the community or at the school. So if your school has a school social worker, talking with that social worker to discuss and see what the next steps might be. If you're on a multidisciplinary team through e-therapy, having conversations in those meetings would be important so that the team can decide what might be the next steps that are best for the child. So you may find that you have children in your classroom that are already receiving services, and maybe children who might need to be receiving services. So I hope today that you have become familiar with several assessments that might be used dependent upon what symptoms are showing, and then would be able to interpret the graphs if you were presented with graphs from those providers treating those children. I hope it has been an invaluable training for you, and I think we're going to go ahead and move on to questions, I believe.
Yes, thank you, Makisha, for that great information. And we are going to move on to some questions now. Let's see. We received a couple of questions about teletherapy in general, and so I wanted to share those answers aloud. One question that I wanted to address is, can students receive mental health services through teletherapy, and are the sessions private? Um, yes, definitely. Students can receive counseling or mental behavioral health services via teletherapy. The student logs on to the session and meets with their certified therapist over the computer. The therapist can hold one on one direct services with the student. They can administer assessments, and they can participate in collaboration with the parent, the teacher, the whole IEP team. And To speak to the privacy question, with e-therapy, the student can be located in their home or in a private area at school. The student sees the therapist face to face through our online platform, and those sessions are password protected and are HIPAA compliant. So that is secure and private, and any student documents or information are transmitted through our STAR platform, which is also private and secure. And another question that was asked, how can I set up e-therapy at my school? And to do that, simply reach out to us by clicking the Contact Us link on our website. You see it there on your screen, electronic-therapy.com, and we'd be happy to speak with you. And now I'll let Makisha address some of the questions that are more specific to our counseling and mental health material here today.
Thank you so much for the thoughtful questions you put in the questions section. I'm going to read a few off that I think would apply, that it would be valuable for everyone to hear the answers, but I'll also be conscious of our time as well. One of the questions was, what do you, the therapist, do when a student doesn't respond truthfully to questions, but you know they are using drugs? So as you know, with any sort of self-report, assessment, that could absolutely be a problem. So really the answer depends on several factors. One, how many sessions you've had with the child, how a therapist may respond to that. If it was session number 2 or session number 15, it would be different. So that's one factor that may dictate the therapist's behavior. Another component that may dictate is what therapy modality that the therapist is using, whether they're using cognitive behavioral or another therapy. And so that may dictate the way in which they respond. Additionally, how the therapist quote knows this information. So is it solid information? Is it coming from maybe a probation officer? Is it coming from a parent? And so taking that into consideration. And depending upon all of those factors, the therapist may do nothing with that info. They also might provide an opportunity for the child to tell a therapist themselves. And the therapist also may bring the information out into the open in a way that's going to be conducive to treatment. So all therapists are going to approach it the same way, given several of those different factors. Let's see, another question. If a student's response over time, the responses on their assessments, are not improving but getting worse, how do you address that in therapy? So you can address it several ways, really. You may assess, as a therapist, you may assess the therapy modality that you're using. So maybe that particular client or child doesn't respond to the modality you're using, and you need to pick a different modality to use. You also may change the approach, and maybe an example of this would be focusing on coping mechanisms instead of unpacking maybe the trauma, the history of the trauma. So you could change the approach in that fashion. You also may assess if maybe they need a different type of treatment. So if you are seeing them in an outpatient capacity, depending on the severity of the symptoms and length, maybe they need either inpatient or a day program, something like that. Or you might decide that they either need an increased frequency in sessions and or maybe a different therapist. Maybe the modality you're trained in isn't working for that child, and maybe not only a different modality, but a different therapist would jive better. So those are all potentials, and there are, of course, more as well, options. Let's see. Another question was how to convince parents to allow their children to participate or make them understand that some students might need help. Whew. Well, I don't know that one can be answered in the 2 minutes that we have left, right? But a lot of times it's an open conversation and asking the parents what they're seeing at home, and coming from a place of concern can also be disarming in some ways, and noticing these are the things I'm seeing in the classroom.
or from an administrator standpoint, and talking about what the family might see as a situation of support. What is something that we could do or get the child involved in that would be supportive, and how I can help you as the parent meet the needs of the child. As you know, it really has to be a disarming conversation, and approached in a way that doesn't get defenses up, and those conversations can be tricky sometimes, right? Yeah. Let's see. The last question: do you share assessment results after a certain amount of time directly with the student? Do they benefit from seeing results? And how do you share or incorporate the student's progress with the student? So it really depends on the therapist. It depends on the age of the child. It depends on the approach in which you take. It depends on how long you've been working with that student. It depends on what issue you're tackling. I think there can be great benefit for a therapist having that conversation with the child and showing them. You know, a lot of times the dialogue, especially if they have negative self-talk, can be that it's not getting better. And if you're able to show the child that they are getting better, that can really change that perception and do wonders for the self-esteem and showing of progress. So I don't want to keep going. I know we are short on time. Our time is over, and so I will hand it back over to you.
Thank you, Makisha, for that wonderful information and for your insights into mental health assessments. It's so great that there are free assessments out there for therapists to utilize, and we're so glad we've been able to share that information here. We're also so glad that you all have been able to join us, and we would love to keep this conversation going. If you have additional questions about this material in particular, or if you would like to learn more about eTherapy, please feel free to reach out to us. You can check us out on Facebook. You can connect with us on our website, electronic-therapy.com. You can click the Contact Us link there to connect with us and continue this conversation. So thank you, everyone, and we will look forward to hearing more from you soon.